Live welcome, good morning, Sunday morning, Memorial Day weekend. If you guys are watching us, this is a great kudo to all of you. It's a new appointment with Journal of Cardiac Surgery. What we like to talk, we call them live talks, 1 hour in a very friendly environment to talk about a topic in cardiothoracic surgery with international recognized experts, learning, educating ourselves, sharing opinions and ideas in a very collaborative way, all sponsored by Journal of Cardiac Surgery. I'm Gianluca Torregrossa, social media editor for Journal of Cardiothoracic Surgery. Today, I have a phenomenal panel of experts. We will talk about aortic valve neocuspidization. We will talk about a paper published on Journal of Cardiac Surgery by the Yale's group. Marcus Crane, that is faculty at Yale University and one of the world leaders in AV Neo, is joining us here today. Arnar Gerson, Chief Division of Cardiac Surgery at Yale, and Andrea Amabile, first author of the paper that we will present today, that is a postdoctoral associate at Yale University and also a candidate for the match of 2023. Together with me, there will be a discussant from Yanagawa, Bobby, and Yanagawa is Chief Division and Program Director in the Division of Cardiovascular Surgery at St. Michael Hospital in Toronto. A dear friend, we were fellow together, and we are here today. So, Andrea, I'll give you immediately the floor. Tell us a little bit more about this paper that you publish in your group published in Journal of Cardiac Surgery. What was the sense of the paper? What was the idea behind it? And then you can present a little bit of the slides that you prepare. Please, Andrea.
Well, thank you so much, Gianluca, for the very, very kind introduction. It's an honor for me to be here today and present our work. I'd like to thank the editorial board for selecting our paper for this month's live talk with the authors. I'm very flattered to be here today. So the paper we're going to talk about today with Dr. Crane, Dr. Gerson, Dr. Yanagawa, and you is about this technique, which is called aortic valve neocuspidization, which was introduced in 2011 by Professor Ozaki, and it's also known as the Ozaki procedure or the Ozaki technique in some part of the literature. And the rationale underlying this technique is to reconstruct the aortic valve using the autologous pericardium of the patient. So there are several pros about developing this technique over other techniques used for the treatment of aortic valve disease. And, one day, Dr. Crane and myself were having kind of an informal conversation like today. He was back from one of his proctoring sections abroad in a developing country, actually. And I was asking him, besides, the technical steps of this procedure, which is standardized in its way and highly detailed and highly reproducible in its nature, I was wondering what are the most frequently nuances that people who are in the phase of learning this technique ask him as an expert. So the idea was really to come up with a manuscript that could be delivered to the readership, and that could be somewhat like someone at advanced level of surgical paper for people to really have the attention on the very details to master this technique. So there's a slide at the bottom of the presentation, Gianluca, if you please, with the cumulative incidence of the procedures over time. And I just wanted to mention before starting asking a few questions to Dr. Crane, this is the cumulative incidence of the procedure over time. And as you can see, the trend is going up in spite of the COVID pandemic, which, as we know, kind of put a huge toll on cardiac surgery procedures worldwide. But the interest is growing, and the interest is growing. This technique is reproducible. There are short and now mid-term outcomes published. Dr. Crane has just presented, in this group of Dr. Crane in Munich, presented mid-term outcomes, TS. And so again, there's growing interest. And so the first question that I would like to ask Dr. Crane is, as an expert, what is truly the rationale behind this procedure? So what was the gap that Ozaki tried to feel when he started thinking about this technique?
So at least I guess from my point of view, I don't know really what have been the thoughts from Professor Ozaki at that time when he developed this procedure. I guess this was much more in the direction of avoiding calcification in standard available porcine or bovine pericardial valves. This was something like the thinking behind the scene from Professor Ozaki. From my personal view is the gap which has to be filled in the future is how we would like to treat younger patients. So do we have a strategy for younger patients to treat them lifelong if they have an age for initial therapy at 40 or 50 years? And how can we avoid to take Coumadin or something like that? And here we have to fill a gap, I guess, or let's say we have to try to be better in the future than we are right now. So of course we can implant a mechanical valve in these patients, and we have a durable solution for these patients with all the drawbacks. But because of the drawbacks, we have to get better in the future. And perhaps we do not know yet a safer answer on that, but perhaps using autologous pericardium, using the suturing technique with the hemodynamic, you can achieve with that. And the results so far, perhaps AV Neo is a possibility to have an answer for these patients having one surgery and perhaps as a lifelong strategy, twice TAVR after that, and they never have to undergo open heart surgery again. Was that a little bit too a long answer? Sorry for that.
Yeah, that was a pretty well detailed answer, Dr. Crane. And actually, thank you, Gianluca, for the slide. We wanted to kind of also include in this presentation this concept of the lifelong treatment and management of aortic valve disease. So, Dr. Crane, would you like to comment a little bit on what is shown with the audience right now?
Yeah, this is exactly what you can think about. This is at the moment more theoretically concept because there is one published case of an AV Neo which was treated with a TAVR prosthesis. But what you can think about is if you have a patient who is 50-year-old and you treat him with a biological prosthesis, and at the moment the data looks like that 1/3 to 50% has to undergo redo surgery or valve in valve at the age of 60, 65, 10 to 15 years, you usually get for 1/3 to 50% out of your patient population. After that, usually in this age class, 60, 65 years, you get another 10 to 15 years. If valve in valve is doing as good as a primary implanted biological prosthesis. We do not know that yet. So gradients are different and so on. So there are perhaps we don't get 10 to 15 years out of a valve-in-valve procedure. But then we have a patient 80 years old. What's to do then with him? And undergoing surgery again, do a valve in a valve in a valve, or how that is called. So this is a little bit a question mark. A theoretical concept could be doing an AV Neo in the first instance, and then do a valve in the native annulus, which you preserved by this technology. Drawbacks of this are at the moment the leaflet height, which could be a problem due to potential coronary occlusion. And another problem is the mode of degeneration. So if you have an AV Neo, the usual mode of degeneration is to get again aortic regurg. And there are not many devices out there who are able at the moment to treat with a TAVR an aortic valve regurgitation. So the Jenner valve is coming back. This could be an option. This is catching the leaflets, could perhaps be an advantage for avoiding coronary occlusion. So there are a couple of technologies coming in the future. But if you do so, then you have perhaps the concept valve in the native annulus, so putting in a large TAVR prosthesis. And after that, if it's degenerate, then you have the possibility of a valve in a valve, basically. And this should be enough if you get with the biological procedures into the age class of 70, then usually you do not ever have to treat these patients. So this is a little bit the calculation behind that, but it's a theoretically concept, one has to say.
Mm-hmm. Very interesting. Bobby, you wrote the editorial on this paper and in a Journal of Cardiac Surgery. Tell us a little bit more, and you are a chief now division. So what is your point of view? Have you ever done a neocuspidization? What is your feelings about it? Do you entertain some potential interest? What do you think are the strengths? What do you think are the weaknesses in your point of view?
Well, thank you, Gianluca. First of all, I love taking credit for other people's work, but it was actually the young fella, Nitish Dhingra, and who actually wrote it. So I won't take credit. This time I won't take credit for someone else's work. But, just one comment is, first of all, I really love the format of this paper. It's just purely, as you say, Andrea, a technical. We are technical people. Our specialty is technical. So this is not about theoretical data. It's not about outcomes. It's not about bravado. It's really authentically trying to teach really important points. So I really felt that in reading this, you're really thinking about the reader and trying to genuinely teach both surgeons and trainees. So I really appreciate that. And I think we should have more of these papers that are straightforward, easy to read, and gets to the point. I have one interesting point. Andrea, you actually asked a very interesting question, which was, what was the rationale or the thought? And I was thinking about Tyrone David, who's of course at Toronto General Hospital in Toronto. And he said, he always says famously, when I was doing the modified Bentall procedure, I was looking at these leaflets, like, why am I throwing them away? Why are we getting rid of this? Somehow we must use this native tissue, which are good. So I was thinking that perhaps, speculating wildly, that someone may have looked at this annulus to say, listen, the leaflets are terrible, but the annulus is just fine. And the annulus is a biological system. It doesn't just sit there. It's, of course, functional. Now we know this. So I wonder if, in this way, that it's no reason to replace the annulus, just the leaflets themselves. Anyway, it's a beautiful, beautiful procedure. I have a couple questions. I guess one is, I'm an educator, and how does a surgeon like myself, for example, mid-career, does not do a lot of aortic valve repair, get into this? How does it learn? And then how would a trainee who's interested in the procedure learn to do this procedure?
Is that a question for me?
Yeah. Go, Marcus. Go for it.
Because I guess I assume that there's no corporations hosting weekend sessions. Cheap. So how do we do this?
Yeah. So first of all, you have to be interested in the procedure, and if you can imagine the advantages of that, then what usually happens is that people reach out to me or other people who are proctoring and have a certain experience for the procedure, and one of us is coming over to you and is helping you, actually. And this is what happens on my own to me. So what happens was that I have had the chance to visit Professor Ozaki in Tokyo, watching him doing the procedure to see it, how it is organized, how is the table organized, how is the sequence of the surgery. And what is also important by that is to get convinced that it is working, because it looks at some points a little bit complex. And every time when I do the procedure, there is a certain point of the procedure where you can't imagine how the valve looks like at the end. And you think, oh, this never will work. And I have this feeling still when I'm doing the procedure, because at some point the valve looks not ready enough. So being with somebody who is doing the procedure convinces you even more that it is doable. You learn about the sequence. And when I have been with Ozaki, we did some of these PIC implantations. So at the moment, what we are doing is taking a plastic model that you can implant leaflets and get used to the stitching sequence and how it's done. And then one of us is coming to your hospital and helping you how to implant that, supervise you in your case, give you something like confidence that if you forget some of the steps, that somebody is there to support you. And then there is a very important time point where you just have to jump into the water and swim by your own. So this is how you learn that. And usually you need something like a case number of 10 to 20 to get very comfortable to the procedure.
Yeah. Dr. Gerson.
So don't do that. So one point is perhaps important. Don't do that just buy this stuff and do it. Don't do it like this. So do that every time with support, because there's so many steps in the sequence that you shouldn't do that. Just buy the stuff and go ahead. Probably not.
Mm-hmm. Yeah, I think it's important to, what has kind of impressed me is really, Usaki really made this, it's pretty detailed how it's done, but it's really a reproducible procedure, exactly, you have the kind of templates, where to put the sutures in the leaflet, how to size the sutures, how to cut it, so there's not much variability. I mean, the variability comes if you're doing a bicuspid valve, which is a little bit more complicated, but I think that is really how, and it is important to stick to that. I think he developed slowly this specific methods, and you shouldn't you shouldn't stray away from that too much. I think that's probably one of the most important things that I've learned from this short period of time we've been doing at Yale.
Dr. Gerson, I have a question for you, and the question is that in this recent year, one of the major, I believe, important advantage or know-how that we have learned from TAVI has been that we overall, as a cardiothoracic surgical community, have really underestimated the concept of a patient prosthesis mismatch, particularly in aortic valve. We are now seeing a lot of ideas about the importance of implanting big size valves, not only to plan for your next TAVI valve-in-valve, but also with the concept of decreasing the amount of stress work, shear, and load and gradient throughout these valves. And AV Neo has among the different potential advantages of AV Neo, there is also the fact that you maintain a patient prosthesis mismatch, particularly in small annulus, that is excellent. Where do you think, where do we live in the current era about patient prosthesis mismatch? There are still a lot of surgeons that do not believe in patient prosthesis mismatch. When you look what is the most implanted size of a biological valve in the United States, if I'm not wrong, is 21. So it's a very small size biological valve. So where do we stand overall, and where do you see us as a community of cardiothoracic surgeons going forward?
Yeah, I mean, I think, there's certainly evidence that came both through partners in the Corval trial that there was an increase in sizes that are implanted for the surgical valves. So I think there's appreciation by surgeons that you really should try to put the biggest, if you're replacing the valve with a biological prosthesis, you try to put the biggest valve as possible. And certainly there's been a lot of interest recently in various methods of enlarging the annulus. And I think, the Mission Group has really published a lot about that. So I think it is important, to try to put as big as a valve as possible. Whether that is true, I think we can argue back and forth. I mean, I do at least severe patient prosthetic mismatch is associated with poorer outcome. There's no doubt in my mind about that. And so that has to be kept in mind, especially in younger patients, and I think it's worth pointing out this great slide that was earlier about the lifetime management. There is actually not much data to help us kind of guide us, the life, how long the durability of the valve. It's really, I mean, this is just purely hypothetical stuff. We have to keep that in mind, but it's kind of the way we have kind of seen this in the way that we present it to the patients. So I think the key is no matter how you should try to put certainly AV Neo has very low gradients because it's inherently just, there's no frame. There's nothing there to restrict the size of the effective orifice area. That's primarily the leaflets, the tissue themselves that do it. So I think as such, this type of strategy makes sense, and the time will tell a little bit, maybe 10, 15 years from now, if that's the case. I think what we're going to be seeing in the next 10, 15, 20 years is like really complicated surgery that has to be done for explantations of different types of valves, and because there's only so much you can put a valve in a valve.
Yeah, metal over metal.
Perhaps just a comment on this discussion about implanting the largest prosthesis as possible. I never have met a surgeon who tries to implant the smallest prosthesis, which is possible. So from my point of view, we do that since we learned how to replace an aortic valve. Every time we implant the largest prosthesis, which is possible for the anatomic annulus. That's what I have learned in Munich, and probably you all have learned during your residency, isn't it? So this discussion about we should implant the largest prosthesis, we do that, isn't it?
We do that, but the one thing I will say is I do warn my residents not to jam a larger prosthesis than the annulus will accept. That is a very dangerous thing.
Yes,
so if you're going to have to do that,
right.
then you have to enlarge the root. So the correct largest prosthesis.
Yeah,
Exactly.
That's it.
Yeah.
And this discussion is somehow funny because we did that already. And you are absolutely right. I can't underline that more. That as soon as you try to put something into the annulus which doesn't fit, which is way too big, you end up with a lot of trouble, and it's dangerous for the patient.
Marcus, I'm not sure that everybody puts in the biggest valve. I remember very vividly 5 years ago, I did a re-op on a 21 millimeter prosthesis, and without doing any enlargement, put a 25 in. So you mean?
I agree with Dr. Gerson.
Yeah,
I think that we still try. It's the concept is I want the patient to go out of the OR. I don't want to have kink of the right coronary artery. I don't want to have the complete heart block. I don't want to have a disruption, and I want to be at the golf yard in the afternoon. So go put that valve as fast as you can. Close the aorta is okay. Patient prosthesis match, we will see. It's a problem of later. I see my patient for 30 days. I don't care. That's unfortunately has been the common theme of heart surgeons for the last 30 years. And I think that not all of us, there's a lot of people who have instead tried to advance the field. But for a really long time, I've heard even leaders in this field just ignoring the concept of PPM and ignoring the concept of trying to upsize at the best the valve.
Of course, I never would say something against measurement of PPM and something like that. This is a valid concept, and this is fine. I just think that, at least in my experience, during the last 15 years, we ever tried to implant the largest prosthesis as possible.
I have a quick question. In mitral repair, you can put patients with a good mitral repair, you can put patients back on their normal survival curve, which I think is the reason why our guidelines are so aggressive. We will do asymptomatic severe MR, but we won't do that for, aortic repair has lagged because our only option for many years was replacing with a clunky kind of sort of biologic or mechanical valve. Would there be any hope of placing these patients back on their normal survival curve with this repair?
Yeah, I guess so. So we just have shown our 5-year results at the AATS, and at the moment we have a survival rate of 98 or 99%. We have one early and one late death out of 160 patients. So at 5 years. So this is probably in this patient population quite good.
Excellent.
And yeah, let's see what the next years will show us. But our population was 53 years old in mean. So they have the life expectancy that you can do the maths you need behind that. I guess so, yeah.
And any risk of, or did you see any risk of endocarditis or sort of halt, what we call sort of subclinical valve thrombosis, etc.? Have you seen this yet?
Yeah, the redos which has to be done in Munich were mainly due to endocarditis, if a redo has to be done. Okay. The weight per patient year is not much higher, like in a typical biological procedure. It's around 1.4% per patient year or something like that. And the biological valve has something like 0.4 to 1%, depending on how you calculate that. So it is there. In, I would say, 80% of the patients, we have a reason for endocarditis. 2 of them developed malignancy. One patient has carotid surgery right before he developed that. There was no endocarditis directly after a couple of days after the procedure, so it seems to be affected by whatever kind of circumstances, which happens in the life of the patient.
I see. Marcus, I do a very fire type of responses for the technical nuances of Ozaki that wants a little bit to interpret the paper and the manuscript. As one of the author of that manuscript, you know, in my very small series of Ozaki, I found it very interesting, try to ask you some detailed question. The first question is, what is, you have proctored around the world, a lot of centers, a lot of surgeons. What do you see is the most common mistake when of a surgeon trying to start the Ozaki program in their first, 5 to 10 cases? What is the most common elements that you see as, or you always try to teach to the surgeon there?
Oh, that's a good question.
Sunday morning, I put you on a corner.
I have had already 2 cups of coffee, but my brain is not still on.
So, you need an Italian one.
Yeah, probably. So what I really emphasize is in every time when I try to educate that is, in your first cases, take your time. Don't be the fastest and quickest surgeon on earth. Just follow the details of the technique, do it step by step, and then you will succeed. But don't try to do that in 60 minutes cross clamp time or something like that. So be calm, follow the steps, and then you will succeed. Technically wise, it's usually doing the commissures is usually a little bit confusing for a couple of people if you start that, because there is a certain sequence of stitches you have to do, then another suture comes into the game, you have to get the sutures out of the aortic wall to the other side and fix them there. Sometimes this stuff is a little bit confusing for people, where they can mess it easily up because then you have the insufficiency there. So technically wise, doing the commissures, in principle, some people just try to be too fast and not accurate enough.
I think a first good case could be endocarditis on a trileaflet valve. Stay away from bicuspid cases or bicuspid for your first training curve, and then start to take a tricuspid valve with endocarditis. Maybe an IV drug abuser, so you know that the compliance can be low in every type of valve. Definitely not a patient in which you want to put a mechanical valve. And hypothetically or theoretically, this is a valve that we hope can have even better long-term durability, considering its self-autologous pericardium rather than a biological valve from xeno material. So when the aortic, there is like the first point is like where do you do your aortic opening, because that is also very important, and how do you expose your valve? That I think is crucial, because if you don't see well, you can't sew well. No, that's a basic principle of surgery. How do you expose the valve and what are your tricks? What do you use? Devices, use something, or?
So first of all, you are absolutely right with your first comment. A tricuspid aortic valve is the best thing to start with. Don't do that with a complicated bicuspid type 0 valve where you have to do neocuspidization and all this stuff. So a tricuspid valve would be perfect. And then to get access to the valve, what Ozaki is recommending, identify your right coronary artery. And from that point on, you measure 1.5 centimeter distally, and there you are doing your aortotomy. If you do that at this place, then you are far away enough from the annulus to suture in the new leaflets, because they are a little bit higher. So you need a certain distance to the annulus to do so. And you are close enough to the valve that you don't have to do that of a distance of something like 3-4 centimeter, where you can easily implant a biological valve, but gets in trouble if you have to do all the stitches for the aortic valve neocuspidization. So 1.5 centimeter above the level of the exit of the right coronary artery. It's a don't do this J incision into the non-coronary sinus. If you get into the situation that you have to do a neocommissure, then you will create these neocommissures in the sinus. And if you have to go into the non-coronary sinus and you cut into that or close into that, then you jeopardize the procedure basically. That's why you do a circumferential aortotomy, 3/4 or something like that. A good case to start actually is when you have to replace the ascending aorta, because then you just cut it away and you have a really nice exposition of your valve and can suture that nicely.
Excellent. We have some questions from the panel. The first question from the various social media where we are streaming. The first question is, considering a patient after having knee 10 years ago needing reoperation, is the annulus still well preserved to take out the old pericardial lift and implant an AV prosthesis without problems?
Is that the question to me?
Yeah, go for it. You probably have experience.
Because so. I can't answer that.
You have not done it?
No, because I don't know how it looks like after 10 years, to be honest. Because so far our population goes back to 2016, so it's 5 years. But what I can tell you from surgeries which has a distance to the index surgery of 2.5 years or 3.5 years, is that the leaflets still looks very nicely. If explantation is very easy, you just cut it away, no calcifications, and the annulus is still intact. So to do a redo aortic valve implantation in these cases is an easy thing, usually. So it's really not a big deal where you have to dig out this ingrowth of a biological procedures, which sometimes can be really challenging. You usually don't have those problems. So yes, you probably can do that. I just can't tell you for 10 years because
you don't know. Yeah.
Luckily, I haven't seen that.
But how do you close your pericardium when you do it? So thinking about a redo, like what do you do with the pericardium that you removed? You leave, you put something. There is a material you like more than others.
No, it doesn't matter what you use, but you should close the gap in the pericardium, that you have something like an artificial pericardium implanted. Don't know which one is better or worse, but you should do something to do your re-entry easier. And sometimes you are harvesting really a big piece of pericardium. So to avoid that the heart is going to the left side is probably also a good thing to implant something.
Excellent.
Yeah,
Go, Bobby.
I really enjoyed the discussion before about patient prosthesis mismatch. I think it's a very interesting topic, also like from the clinical outcome standpoint. And I just wanted to share with the people who are listening to us that there are 2 case series out there about the use of AV Neo in small aortic annuli. One actually are midterm results that have been published a couple of years ago by Akiyama about AV Neo in patients with small aortic annuli, and the other paper has been published in 2020 by the group at Boston Children's Hospital about performing AV Neo and aortic annular enlargement. So this is something that there's some data out there that's been, it's interesting to look at for those who are interested. I would like to ask one question to Dr. Crane that maybe of interest to people who are listening. Once somebody starts mastering the learning curve, and so like goes over the first technical steps and start feeling comfortable with the procedure, are there any patients that should be absolutely not be indicated to AV Neo from the clinical standpoint and from the anatomical standpoint? What are your absolute contraindications, if any, to this procedure?
Oh, that's a good question. I think in general there is no contraindication. As soon as you can do an aortic valve replacement, you can do it using the AV Neo technique or the Ozaki technique to implant the leaflets. What I didn't do or wouldn't recommend is on one side doing that in an aortic valve endocarditis case where you have an abscess in the annulus, so where you have to close this with a patch or something like that, because you are jeopardizing one of the advantages of the procedure. This annulus won't move anymore like the native annulus could do. So a really severe endocarditis I wouldn't treat where you have to patch the annulus. A second one is if you have to replace the root and do something like a Banter procedure using the tube graft and implanting autologous pericardial leaflets into this tube graft. It is done. You can do that, but also this is jeopardizing the benefit of having the native annulus and all the stuff. So in this patients, I would just go for a standard Banter procedure. But this is just a relative contraindication because of my understanding. But Anna, what do you think?
Yeah, I don't know, Marcus. Do you have any age cutoff that you guys did at especially in Munich? We've talked about a lot about probably the patient who benefits the most in somewhere between 40 and 60, but certainly Ozaki did a lot of his cases in an elderly patients, right? And that's been some of the criticism of his kind of outcomes, that you don't have where you advocate or think the best thing is to do it in younger patient, but the long-term data is not there yet. So.
Yeah, you are absolutely right. And so what data can tell us, as far as I know them, is that if you are beyond an age of 65 or 70, and you get a biological prosthesis, your chances of a redo procedure that you need one is something like 10% over the rest of your life. It's really, really low. So 90% are free of any aortic valve redo surgeries if you are older than 65 or 70. So I don't know if there's a need for AV Neo in patients who are 72 years or something like that, or 70 years. because we have a good modality to treat these patients. And this is standardized, this works quite well, this is a fast operation, a safe operation, that's good. That's why your question is really well taken, that is there a certain age class you wouldn't recommend that for, and probably everything what is about 70 does not need to undergo AV neo or need an alternative.
For sure.
Okay.
When you speak about AV neo, there is always, of course, the concept of a ROS procedure that needs to be discussed, in the sense that ROS has effectively excellent outcomes, is a beautiful operation. For sure, it's technical demanding, but at the end, even AV neo has its nuances. But where do you see, and I will asking this one, Dr. Gerson, like where do you see in that similar charts that we were showing before, what is in the current era the role of ROS procedure? If you were a young surgeon interested in aortic, do you think someone should learn each one of these techniques and master all of them? Or do you think that AV neo can try to compete and take some of the ROS patients? What is the discussion of ROS versus AV neo?
Yeah, I mean, I don't think they really compete a little bit. I guess, in my mind, the primary role for ROS is the younger patients, like, less than 40 years of age, maybe, and patients who have, require root replacement. I think what it is important, and it's an excellent question for Dr. Chu here, the really, but ROS is a technical operation. It kind of fell out of favor, and I think most of my generation surgeons, unless you're a congenital surgeon, have not been exposed adequately to the ROS procedure during their training. So I think that's, and you have to replace. It's a 2-valve procedure. So I think in properly resected patient at a center who does a lot of them, I think it's really good outcomes. I mean, there was at the ATS from a fairly sizable center that one can argue the outcomes of ROS were not the greatest, in the long term. So I think for the properly selected patient, younger than 40 or so, it's probably the way to go. And then when you do have to do a root replacement and you don't want to do a regular standard bento.
Mm-hmm. Sounds great. Bobby, what do you think? You've been at Mount Sinai, one of the, we were there together as fellow, and we enjoy our time with Paul Stelzer singing song at 2:00 in the morning after the third ROS of the day. and you remember those days.
I remember those days fondly. As you know, I don't perform ROS. I just perform sort of standard, straightforward aortic valve placement. So I won't really comment on that aspect of it because I'm more of an observer. A quick question: what is your anticoagulation or antiplatelet regimen after these procedures?
Marcus.
Oh, it's me again.
yeah, it's you again. Back in action.
Yeah, that's a good question. So our procedure is aspirin 6 months, but there's no evidence for that, because this is just thrown out from Professor Ozaki doing that. But of course, there are no data of that. Mm-hmm. So there is no comparison to warfarin versus aspirin or doing nothing. So it's gut feeling, and we adapted that from Professor Ozaki, and this is 6 months aspirin, mm-hmm. And then do nothing else.
Mm-hmm. Yeah. We have some other question about the autologous pericardium. It was effectively introduced in the past. Duran, there are some report of Batista. I received now some text also from Thomas Salerno, the editor-in-chief that is watching us of Journal of Cardiac Surgery. He was saying, well, Batista introduced for single leaflet in back in the days. one of the elements is like, how do you treat your pericardium? What do you think about these single leaflets? I remember, like, before Ozaki came out with his own series, one of the during my training, I remember a lot of conflicting evidence about the long-term results of the pericardium fixed with glutaraldehyde. Is there really the best way to do it? Can we do in a different way? Should we add an antibiotic when you fix it with a glutaraldehyde? Do you do anything to try to innovate the way in which we treat the pericardium before we implant it, hoping that we can have a better outcomes?
Okay, this have been 10 questions in one. I try to answer every one of them.
Go for it.
First of all, I like very much this comment from Antonio mentioning Duran, because this is correct. Autologous pericardium has been used since the early 60s by Edwards himself, untreated, implanted for leaflet extension, with bad results, which he reported actually in the 60s. And Duran did this procedure in the 80s and published his results, which has been quite good at that time, one has to say. Difference between Duran and Ozaki is the standardization. The idea from Ozaki is not using autologous pericardium for aortic valve replacement. Others did that before. But the standardization of the procedure, that everybody can do that, this is the real achievement from Professor Ozaki. So having said that, how to treat the pericardium? Duran treated it in a similar way. And if you screen the literature, if somebody is treating pericardium for valvular surgery, all of them are doing that in a more or less similar way, using 0.4 up to 0.6% of glutaraldehyde and fixing that something like 5 to 10 minutes. Some are washing that in a standardized way, some not. Ozaki's recommendation is 0.6% glutaraldehyde, fix it for 10 minutes, wash it 3 times for each 6 minutes. So in total, almost 20 minutes. Then you decrease the concentration of glutaraldehyde very much. Mm-hmm. And so far it works quite well. I remember when I started the procedure in Munich, people told me all these valves will fail within 1 or 2 years, all of them, because autologous pericardium is a bad thing to do. All of that is calcifying and so on. So far, I can tell you up to 5 years after that, it's not true. The valves are running quite nicely. Leaflets are quite mobile. No signs of stenosis. So at the moment, they are doing well. Duran's results were very good. His mean age in his papers were something like 30-something years. So actually, it's not that bad, autologous pericardium, treating it like this. So probably I just answered one question and missed 8, but I talked a lot.
It's me. Like I've just create way too many in few seconds. That's my brain. You know. I mean, guys, we are almost at 50 minutes. We have one more question from the panel of people that are looking at the people that are looking at us from the different social media. And Ozaki in annular ectasia. Do you this is another element, and if you think when just to compare with Ross's, when you look the results of Ross in AI, because Ross in AS is a great, in my opinion, operation, but Ross in aortic regurgitation or in annulus that is dilated, the results can be mixed. And what is your patient like in AI? Ozaki should be a very valuable opportunity. I think actually an AI should be your first case. No, what do you think, Marcus? What do you think, Dr. Gerson?
Anna, go ahead. I'm talking all the time.
Yeah, no, I think you're right. I think you have to be careful. Is that if you do, in some of those cases, if you have a root enlargement, replacement of the ascending aorta, hemiarch, and aortic enlargement, you should just do a root replacement. You maybe should do a David procedure or just a regular composite biological or mechanical root. So, so I think you have to be careful with that. If there's a tendency for, I think that the procedure somewhat depends on a somewhat stable annulus. It's not going to dilate over time. And utilizing native annulus to maintain its stability and once you reconstruct it. So,
Andrea, take the floor. Tell us something.
Well, it's very, very amazing educational experience also for me to listen, to all these expert opinion and to kind of, get the inputs from the floor and from the panel. I think this is one of your videos, Gianluca, correct?
I think this is my first Ozaki that I've done at Mount Sinai with Dr. John Pascas. I was helping him. I made him so much headache because I was so excited about Ozaki that he told me, just do it. And the patients that we have done it in 8 patients, they did. I had a very good outcomes in these patients. In most of them, I think it's an excellent opportunity to. And these one were all endocarditis patients that comes with isolated, so endocarditis of the leaflets, nothing in the annulus, and they came in and they have instead of a biological valve, they have an Ozaki.
That's wonderful. That looks really great. And what I would like to point out is your retractor.
Yeah.
In Munich, we use the same thing with the small valves that you have in the non and the right coronary sinus. You have this retractor in, and you can expose the aortic valve very, very nicely by that. Have no movement in your operating field. So, and look at that beautiful result. Looks perfect.
Thank you.
Congrats to that.
Yeah, thank you. It was nice. It was very nice. I loved it, and I have to tell you, it's. I believe personally, it's beautiful to do it. It's beautiful to see the reconstruction of the valve, and for sure, one of the question has always been like, how do you
have a look at that
size-
opening?
That's
have a
nice.
Look at that. That's really nice.
Yeah. Is it possible to test or to assess the coaptation before you take the clamp off?
Yeah, so it should show a typical windmile configuration, and you can make sure that you have all 3 commissures and the distal. Go back to your final visible result, Gianluca, then we can discuss that a little bit. So like this.
Nope.
Nice.
It should be in a few seconds from here. Oh.
But
you get it. You will be there soon. Keep that. Stop that.
Oh. Okay. You keep talking, and I need more coffee.
Okay,
too.
That's good. Take out the sucker. Okay, we have it here. So what you want to have, stop it, is that all commissures, and you can't see this one, but all commissures and the distal point of your coaptation, this should be on one plane level. This is one thing you would like to achieve. You can, of course, keep your vent running, your LV vent running. Here you can see that also. Here everything is on one level to the distal coaptation part. You can keep your vent running and see if it makes some negative pressure. But at the end, you really want to have your echo looking good, because once this valve is under pressure, it behaves a little bit different. The root behaves a little bit different. So you can assume if it looks good in the echo, but you are never sure. It's every time a moment of tension once you open the clamp and get to the echo.
Yeah, that's.
Do you have any specific parameters, Dr. Crane, that you ask to your anesthesiologist to look at the echo in terms of quality control?
Yeah, what is really nice to have, and Gianluca, play your echo again, because all of what you want to see was in there. So what you really want to see is the large coaptation, like here.
Mm.
So this is usually something like 1.5 centimeter. And what we have learned from aortic valve repair is that you need to have, for a good durability, you need to have a certain coaptation height in the aortic valve, which is how your repair usually is designed to achieve that. And what you have is Ozaki is 1.5 centimeter, which is really good, really long. And one advantage is of the procedure to guarantee a competent aortic valve. So you want to have that, and go ahead. Then you have the short axis view here, where you want to see that all leaflets are mobile, and look at that. You probably see that very, very rarely using a biological procedure, that the opening is almost the whole root, isn't it?
Yeah.
So it couldn't be much more. There is no more room for opening. And you can imagine that by this opening, you really have a nice hemodynamic scenario. So you want to see that, and just one click further, you want to stop it when it's closed. And this is another thing you want to see. You want to see the symmetry. What you really would like to avoid is to have one real small leaflet, something which is really, really tiny, and two large leaflets. Because if you do not follow the rule to implant only one size difference in leaflet sizes, so for example, 29, 29, 31, it's good. If you do 25, 31, 31 and have this huge mismatch between sizes, then the two big ones can push the smaller one away. And this leads to asymmetry, which could lead to a leaking valve or even coronary occlusion if the smaller one sits towards a coronary sinus. So what you really want to see in terms of quality is a symmetric tricuspid valve with a nice opening in the short axis view. And then you probably have a good result at the end. Like you achieved here, it's a brilliant result, Gianluca.
Merci. Thank you. Grazie, actually. No, it was definitely a very interesting experience to do these cases, and I think something will be when you start to say mobilize a commissure, start to approach unicuspid, bicuspid. That's something that's requires some. But starting with this tricuspid endocarditis, I think that it's just like you take your time, you go slow, you review your videos, you do some of these. I invited Ozaki at that time. He came over. I did the same training on that plastic route. I remember when I was just a fellow, I was very interested, and I went. We were doing recruitment of the heart for Anyanvu, Aneleki Anyanvu. We were flying all over the United States, and when I was coming back, when he was taking out the heart, I was opening the aorta and I was doing an AV neo on the heart of the transplanted heart to practice. And so it was you do some of this bench, and then you do your first case, and it's like you can be successful slowly, as you said, very slowly. Take your time. This is precise. Use cardioplegia and be very detail oriented as everything in surgery. But even I'm not an aortic surgeon. I can do it. So I mean, it's okay, guys. I think it's almost time to wrap up. It's 58 minutes. Bobby has a case to do on a Sunday morning. He's very committed to have surgery. I have to babysit. My wife is working in the hospital. I think I'm alone with the baby. I don't know even where she is. And my wife tells me I cannot use the word babysitting when the daughter is mine. So I think, yeah. But at least I have to prepare some breakfast. So I want to say thanks to all of you guys for coming and joining on a Sunday morning. Thank you so much. It was a very fun and nice conversation. And really thank you for the attention. We have one question from Albertini here. Absence of early degeneration is confirmed in many series. probably the key point are the extremely low gradient, the absence of immune response. And we can close with this one. Thanks again to Journal of Cardiac Surgery and Thomas Salerno that help us with all of these live talks. And looking for our next appointment, and hopefully look forward to see and meet again all of you in a next meeting. I will end the broadcast from the live, but